It's my pleasure to present today the results of our recent joint study in between the University of Washington, Philips Healthcare, and Moscow State University on how to use shockwave exposures for accelerating thermal ablation of confined tissue volumes. So our study was motivated by the existing current challenges of thermal HIFU that were discussed earlier yesterday in the session. And these challenges, they actually originate from the thermal by-effect of the treatment. For example, near-field heating is unavoidable when we treat large volumes. When we treat with some trajectories, the heating volume is elongated at the targeted site along the ultrasound beam axis because of thermal diffusion. Treatments close to critical structures such as bones, skins, or vessels are challenging, and the patients that can be involved in the studies are smaller than it can be. So there are some exclusion criteria. Long treatment times because we need to wait in between treatments, and there is a strong heat sink effect in highly perfused organs. So the idea of this study was whether we can use nonlinear effects and shockwave heating to address and mitigate these challenges. So in high-intensity focused ultrasound fields, nonlinear propagation effects, they accumulate over the distance from the source to the focus, and they may result in formation in shock fronts at the focus with amplitudes that can exceed 100 megapascal. And these shock waves, they can heat tissue at the target site so efficiently, like 10 times more efficient than the harmonic waves of the same amplitude, and may result in tissue rise up to boiling temperatures in milliseconds. You can reach boiling in milliseconds in such fields. This effect has been used in the recently proposed technology termed boiling histotripsy, which is under development of the University of Washington. This is a pulse treatment using millisecond-long pulses, and localized boiling is due to shockwave heating is introduced in each pulse, and then interaction of shock waves with this bubble, it results in mechanical disintegration of tissue that George Shade talked about in his presentation earlier. So this is the mechanical effect initiated by enhanced shockwave heating. So then the question is whether we can use this accelerated heating in pure thermal treatments, and that was the goal of this study. So first, the question is whether we can reach these shockwave regimes in the existing clinical systems. And we worked with the Philips Sonalive V1 system. We characterized the field, and we showed that really, both in modeling and experiments, that shock amplitudes of more than over 100 megapascal can be reached in such a clinical system. And we also did ex vivo studies in bovine liver samples, showing that shockwave exposures can be used to do boiling histotripsy. And so now we wanted to explore whether we can use it to address these challenges of purely thermal treatments, and whether we can use it for volumetric treatments. So this is, at the moment, a numerical study. We simulated this ex vivo experiment that we did in this clinical system. We modeled acoustic field in the tissue sample for 256 element array of the 1.2 megahertz transducer of the system. We used Westervelt equation for that, and we combined it with the Byheat equation for heating tissue volume and calculated tissue dose to determine what kind of volume was ablated. We used two treatment protocols that I will show you the results. So the first one, the the power was related to the clinically used power that was about 100 acoustic watts. The acoustic waveform at the focus was just slightly distorted. It's almost continuous wave and harmonic wave exposure. And we electronically steer the focus over a discrete set of sonication points on the circular trajectory, 4 millimeters, the outer ring. So that would be about 1 centimeter circle of ablated tissue in the focal plane, and it's similar to what is shown in the middle. And for shockwave therapy, we used shorter pulses so that the overall time average power was the same, so the near field effect would be the same, but we can treat faster, and probably there are some other advantages. And we modified a little bit the trajectory because shockwaves are very localized, so we wanted some finer discrete point steps between them. That was 1 millimeter instead of 2 millimeters in the conventional protocol. And so now we can see how these treatments evolve. On the top is this conventional treatment, on the bottom is shockwave treatment, and the shockwave treatment is looped because it happens very fast. So we see that in the focal plane, actually the structure of the heated field is similar, but in the axial plane it's very different because conventional treatment is slow. We ablate pretty large volume, but the heated volume we heat in the middle, but the ablated volume it's elongated along the axis. So it's not very predictable because of the heat diffusion. And the shockwave heating is actually whatever is ablated, it follows the geometry of the heat deposition that we induce. And the next, so here is the summary of these two cases, and we see that in the focal region everything is similar, but in the axial it's very different. Ablative rates are similar. However, we can induce confined, very well predicted lesions with shockwave heating, and it happens very fast. So we can actually combine these small volumes into the larger volume for treating larger tumors. So this is just one layer, and we also examine what would happen if we induce 2-3 layers of shockwave exposures, 5 millimeter beyond the focal plane, in the focal plane, and before the focal plane, so they can reuse this heating effect which is nearby this one layer. And this will show you what happens. There is an axial plane on the bottom and 3 planes in which we treat, which is beyond the focus of the right, in the focal plane, in the middle, and before the focal plane. And we can see that the heating is very uniform. And even with these 3 layers of sonication trajectories, the heated region and ablated region follows the geometry of heat deposition. So it's very predictable. And what is interesting that the ablative rate is more than 2-fold faster than comparing to the conventional treatment. Here we see the final result. Red contours are the contour of the ablated tissue. And we can see that the volumes are similar, but time is much faster for shockwave heating, and ablation rate is much faster, more than 2-fold faster, which is kind of promising. So here we have these results summarized, and the main point is if we want something very localized, for example, close to critical structure, we can use shockwave heating to rapidly ablate this target site without worrying too much about heat diffusion because everything happens very rapid. And if we want to ablate larger volumes, we still can use shockwave heating, and we can accelerate the treatment at least 2 times or maybe even more. So shockwave heating, confined uniform ablation, multiple layers, we can get high ablation rate comparing to conventional volumetric treatments. So in conclusion, we have shown that volumetric thermal lesions may be generated utilizing shockwave exposures, and we can do it on a clinical MR HIFU system. And comparing to conventional treatments, shockwave heating can shockwave heating can reduce the effect on the near field and surrounding tissues, can mitigate diffusion-perfusion effects, and we can get sharper boundaries of the treatment margins. So it's pretty promising, and we're looking forward to optimize more these trajectories and implement it in experiment. Thank you.
We're running really late on time. I just have one quick question. Have you done any ex vivo studies to validate the models that you've shown?
Yes, we did it in the system, and while we did boiling histotrips experiment, we also tried some irradiations with thermal effect, and that was actually also one of the motivations that we continued, because we can accelerate, and there were very sharp margins around the thermal ablated lesion.
Thank you very much.
Can I ask a question?
Sure.
Sorry.
Quick question.
Yep. So do you have any increased risk of heating right under the skull?
Excuse me?
Would you?
Can you heat under the skull with this method?
No, would you have an increased risk of unwanted heating with the shockwave therapy?
No, that's actually, we decrease the risk, because whatever shock waves do, it only happens very close to the focus. So the rest is actually safer than in conventional treatments, because we do the same, but with a short exposure time.